Before we begin our discussion, Kelly Harris, CEO of Cancer Support Community Greater Philadelphia, would like to welcome you.
Hi, everyone. I'm so glad that you all could join us tonight for this really important presentation. I'd like to start out by thanking our intern, Finn Connor, who has done a fantastic job of pulling this together. I'd like to thank our amazing panelists who have joined us, taking time out of their busy schedules to participate in tonight's event. And of course, I'd like to thank our staff who've worked with all of us to make sure we could do this presentation. I want to take a minute and talk about Cancer Support Community Greater Philadelphia. For the last 26 years, we have provided a program of free support for anyone living with any type of cancer and their family members and friends. We have support groups, individual counseling, education, mind-body programs, social events at 5 locations across the Philadelphia area. That was prior to COVID-19. Currently, all of those programs are being offered virtually, and I'm happy to say that we have had a great amount of attendance, so we are continuing to expand our scope and reach. I think all of us realize over these past few months the importance of diversity in our world and the attention that needs to be paid to it. So I'm especially thrilled as a member of the LGBTQ plus community to participate in tonight's event and know that this is a start. This is a start for a lot of different types of presentations we want to make, and we want to hear from you about what you would like to hear from us. So at the close of this, in the days following the event, as you have a chance to think about it, please contact us and let us know what you would like to hear and how we can continue to grow our diversity and our accessibility to people across the Philadelphia area. Thank you. Thank you, Finn.
Thank you, Kelly. I'm Finn Connor. My pronouns are he, him, and I will be moderating this panel discussion. I'm a social work intern at Cancer Support Community Greater Philadelphia. I'm also an undergraduate student at Washington and Lee University, studying cognitive and behavioral science with minors in poverty and human capability studies and theater. I created this panel because I believed it's important to recognize intersectionality, particularly for historically marginalized groups such as the LGBTQ plus community. Queer individuals are often left out of the conversation, but in this conversation, queer individuals and queer experiences are at the forefront. We will be beginning with prepared questions, but if you have a question you would like me to ask our panelists, you can send it in the chat. I'd like to thank our panelists for joining us tonight. Dr. Monique Gary is a board-certified, fellowship-trained breast surgical oncologist and medical director of the Grandview Health / Penn Center Network Cancer Program in Sellersville, Pennsylvania, where she also serves as director of the breast program. Dr. Gary completed her medical degree at the Philadelphia College of Osteopathic Medicine and her general surgery training at the University of Massachusetts Berkshire campus, as well as a breast surgical oncology fellowship at Georgetown University. As a physician, advocate, and key opinion leader on cancer and healthcare disparities, she is passionate about developing integrative, holistic, and innovative approaches to cancer treatment, prevention, and health equity in our region and throughout the world. Dr. Gary is a proud member of the LGBTQ plus community in Philadelphia and serves on the board of local and national advocacy and support organizations, including CSCGP. Dr. Gary was recognized as a leading physicians of the world and top breast surgeon in Pennsylvania for 2017, 2018, and 2019, and is a fellow of the American College of Surgeons, the highest distinction awarded to surgeons in the nation. Dr. Sar Gill is a hematologist-oncologist at the University of Pennsylvania, where he specializes in the treatment of leukemia. He obtained his medical degree and PhD from the University of Melbourne in Australia before moving to the US in 2008 to pursue postdoctoral research in the field of bone marrow transplantation at Stanford University. Since 2011, he has been at Penn, where he runs a research lab, treats patients, and mentors graduate students, medical students, and postdoctoral researchers. He is a founding member of the Special Interest Group for Underrepresented Minorities of the American Society of Transplantation and Cell Therapy. He lives in Philadelphia with his husband and 2 dogs, and during normal non-COVID times, he enjoys traveling the world. Chris Pope is a diversity, equity, inclusion, and belonging consultant with experience in retail, finance, and nonprofit healthcare industries. He has served on multiple DEIB initiatives, including improving employee engagement, Diversity Council and Employee Resource Group Development, nonprofit board work in the LGBT plus healthcare community. Chris holds a BS through Cairn University and an MBA through Temple University and a Diversity and Inclusion certification through Cornell University. Chris is a lover of reading, podcasts, hiking, meditation, and is a hot room yoga instructor. He lives with his 19-year-old son, Elijah, in Huntington Valley, Pennsylvania. Michelle Veras is the product director of the National LGBT Cancer Network's Tobacco-Related Cancer Project. Working at their office in Pawtucket, Rhode Island, Michelle manages the day-to-day operations of the project. After more than 10 years of nonprofit youth development and community health work, she joined the network in 2018. Michelle is passionate about the systems-level health change that she works on through the Tobacco-Related Cancer Project. A native of Providence, Rhode Island, Michelle obtained a bachelor's degree in sociology from Providence College and a Master of Public Health degree from Brown University. Michelle is Latina, a mother of one, and identifies as queer. Now that I have introduced our panelists, we'll begin with prepared questions. If you have a question you would like asked, send it in the chat. If we don't get a chance to get to your question in the panel portion, you will have the opportunity to ask it directly to the panelists in the breakout rooms portion in the second half of this event. Beginning with our first question, what is your connection to the LGBTQ plus community and or the cancer community? I'll start with Chris.
Excellent, thank you, and welcome everybody to the panel today. My connection is primarily to the LGBT plus community at large, but specifically to the healthcare community. I served as a board member. I was eventually treasurer, chair of the development committee, and eventual president of the board at Mazzoni Center, which is the largest LGBT plus healthcare organization in the region. So we had 35,000 clients, about 5,000 of those were out transgender patients. And so through the leadership of that organization, some restructure, some racial bias work that we did there, that's my main connection to the LGBT plus community and specifically to the healthcare community.
Thank you. Dr. Gill?
So my connection is, I guess, largely to cancer treatment, since that's what I live and breathe. But and I don't specifically treat LGBTQ individuals as part of my practice, not specifically at least, but I've always been very intrigued to think about the experiences of LGBTQ individuals with respect to cancer diagnosis, the cancer journey, and cancer treatment. And obviously, in large part, that stems from my own experiences. And so I have to confess, this is the first time I've done one of these panels, and very, very used to doing panels for talking about science and the progress of medicine. But I was equally intrigued to hear from you, from the panel, as well as from the audience, and to try and provide some of my own experience.
Thank you. Dr. Gary?
Thank you so much for having me this evening. I have the unique opportunity to sit at the intersection of the LGBT community and the cancer community, because I'm a member of both, you know, in the sense that I am a lesbian, and I take care of cancer patients as director of the cancer program at Grandview Health. I specialize in breast cancer surgery, and it has been an interesting journey watching the practice evolve in the sense that we have at Grandview been really striving to make our understanding and our explanations and our responsiveness to cancer patients much more inclusive of all the communities. And this has been, it's a work in progress, I think, because when patients find out, and I disclose how I identify and my experience within the LGBTQ community, you see the sense of relief that comes over them because they feel understood, they feel affirmed, they feel heard, and so it's just a really a great journey so far, and I'm really looking forward to sharing with everybody on the panel today.
Thank you for your insight. I can't currently see Michelle. Michelle, can you hear us right now? She may be having some tech issues. Oh, there she is.
I could see you and hear you. Hi.
Wonderful. Michelle, what is your connection to the LGBTQ plus community and the cancer community?
Sure. So I am a queer woman. I'm Latina. I don't have a personal connection to cancer. My background is in public health, but I was brought to this work 2 years ago now when I was hired by the National LGBT Cancer Network to work on a tobacco-related cancer project. And through that work, we really focus on educating LGBTQ folks about our increased risks of cancer, training healthcare providers to create more welcoming and affirming settings for care, and then advocating for inclusion of queer folks in mainstream cancer research and cancer support groups. Thanks for having me tonight.
So Michelle, you mentioned that your work is at the intersection of this community. In what ways can occupying an LGBTQ plus identity complicate a cancer diagnosis?
Sure. So I think that many queer patients are faced with the choice of whether or not to disclose our sexual orientation to providers. I think about that when I go, to the dentist, to the therapist. So imagine going through cancer treatment, and there are just so many providers that you encounter along the way. There might be a surgeon, an oncologist, a chemo provider, and at every point having to question whether or not it's safe to come out and whether your chosen family will be accepted as a part of your support team. And I think for trans patients, that is an even more precarious situation. There's been some research suggesting that most oncologists don't actually feel like they have enough knowledge to treat trans cancer patients.
So talking about treating queer patients, in your experience, Dr. Gill and Dr. Gary, what are difficulties that LGBTQ plus individuals face in receiving healthcare? We'll start with Dr. Gill.
Okay, thank you. So I think to echo some of what Michelle was saying, that is surely one of the factors with respect to disclosure. In my practice, one of the things I love about my practice is that I get to see people for a very long time, sometimes for forever. I like to tell them sometimes that we'll grow old together, and so that is a component of that, of course, is getting to know their family. Because of the particular field of oncology that I practice, which is leukemia and bone marrow transplantation, it's very important to get to know the family because of several reasons. One is the possibility of inherited diseases or inherited predisposition to leukemias, for example. But even more commonly, we often need to reach out and involve the family in order to look for potential bone marrow donors. And so there is a lot of interaction with the family and seeing the degree to which the patient is accepted or otherwise, and what the nature and strength of their relationship is with their family is vitally important. And so unfortunately, sometimes that is, everyone can have difficulty with their family, but being queer or transgender can have those additional hurdles that in this particular case, at least in my professional experience, can complicate things.
Dr. Gary, what are your thoughts?
My thoughts are that cancer care begins, or healthcare really starts, at prevention. And if your relationship with the healthcare system is fragmented and or non-existent due to many factors, so social determinants of health, having multiple addresses, we find that members of the queer community may move around and migrate more and may not have consistent providers. They may have an unwelcoming experience at a provider's office that then translates into not seeking care that is preventive. So if your routine screening is disrupted, then your relationship when a cancer diagnosis happens is that many times it's late diagnosis. And the treatment options then become a bit more complicated, and there is this distrust of the medical system that has really deep roots. And so it makes the cancer journey that much more difficult. I think that in addition to that, we fear a stigma with respect to coming out to our providers and having to do it again and again and again because the practices themselves are not affirming. And the last thing I'll say is that with the cancer journey, there is a lot less navigation, I think, that happens for our queer community, much as it does with HIV, the HIV positive community, even with our cisgendered breast cancer and other cancer patients. There's a lot more navigation toward resources, and I think that we have not yet really developed the navigational pathways to assist our queer community in their cancer journey, and so that's something we need to fully develop as well.
Dr. Gary, you spoke about the social determinants of health and particularly about prevention. Going off of that, I have another question for you and Dr. Gill. LGBTQ plus individuals have higher rates of some cancers, including elevated cancer risk factors such as increased rates of drinking, smoking, and obesity. How can the medical community best address these concerns for the LGBTQ community?
I guess I'll start with that one. So how can we best address it? I think that, providing visual clues that our practices are affirming and are safe spaces can help to encourage our members of our community to seek out preventive practices. Providing resources for free and reduced cost screenings and bringing screenings directly to our communities and to those patients is a huge part of addressing those concerns. Even things as simple as customizing our intake forms. I'm going through a process now with my hospital whereby we are beginning to customize our intake forms and to make our bathrooms gender neutral bathrooms, things of that nature that just make a person feel more welcome to even seek out care. And then I think there are some guidelines and benchmarks that we could strive for. There are increasingly a number of guidelines for LGBTQ care that will make they help to normalize for some of what we do and to help measure some of what we do, because there are not really clear metrics that measure the success of our individual campaigns either.
Dr. Gill, what are your thoughts?
I agree with the statement about normalization. Another aspect of it is going back to your question, Finn, about risk factors and some at-risk behaviors, and keeping in mind why this particular cancer developed in this particular individual, and what components of this individual's life and life journey have brought them this far. And going back to my earlier point also about certainly late diagnosis, delayed diagnosis, but also ability to participate in pretty complicated care, be it because of lack of social supports, or perhaps because of concern that their, for example, a significant other would not be welcome or would not be accepted coming along with them to the clinic. And also other aspects, for example, drug and alcohol or tobacco usage that may have either contributed or may make it more difficult to pursue this sort of care and this sort of treatment that are prescribed. So I think all those are, I think as doctors, we can always do better, and we can always spend more time and think more deeply about what factors are complicating the journey and the life of the individual before us. I try to remember that every time I see a person in front of me for their cancer treatment, and knowing what context or what background this individual comes from can certainly help to tailor, can help to improve the care and the outcomes.
Dr. Gill, you spoke to how the things can complicate before you reach to, and I think we've established that cancer uniquely impacts the LGBTQ community. But some of the cancer experience is harshly gendered, such as breast cancer often only being discussed as appearing in women when it exists in both cisgender and transgender men. How can we be more gender inclusive within the cancer community? We'll start with Chris to answer that.
So I am going to take more of a macro view of this with my work with diversity inclusion work, separate from the healthcare profession. I think that there are certain aspects of this that apply to pretty much any situation. So to be more gender inclusive, I think first of all, healthcare professionals need to recognize that whenever they come to any appointment with a client, with a patient, that there are biases that they already have. And rather than trying to ignore those that are there, actually be able to acknowledge them, analyze them in the moment, and then be able to move through them rather than trying to act like they don't exist. So for instance, if someone came into an appointment who presents female, my assumption is, I've been socialized to believe that when they walk in, I'm going to make an assumption that this is a person who was born female. Part of the practice of diversity inclusion work is that I need to recognize that that's a bias, that there are some assumptions that could be made about this person because I'm assuming that they were female at birth. I need to be able to acknowledge that and then set that aside and then be able to see this person as the individual in front of me and get all of the information that I need in this moment while trying to acknowledge that I might have some biases. Does that make sense?
Oh, yes. Thank you, Chris.
Okay. So that's number one. I think that that's the most important part, is that we need to train healthcare professionals how to walk through that process. I think that that's something that's a little bit difficult and we don't necessarily have the training. Second, some of the things that Dr. Gary had said before, there are certain outside structural things that we can do. So for instance, allowing self-identification through forms or through logging into a system so that I can choose something besides male or female. So I can choose gender non-binary, I can choose trans as an option. Those are the types of things so that I, as the patient, am feeding as much of the information into the system without having you as the healthcare professional guess what my situation might be. Another one would be making pronouns not just a part of a practice where I might have my pronouns. So for instance, I go by he, him pronouns. And so I might have that as a part of a name tag, but actually training healthcare professionals to make that a part of their introduction, even if they might identify with the gender that they were born with. Making that the part of the practice makes it more comfortable for trans folks to be able to use their pronouns in public. And so that they know that this is a part of the practice, they can feel free and able to do that and as a part of that too. I would also like to make a plug for those healthcare professionals and anybody who's in your circles, a 2-hour training on gender or a 2-hour training on anti-racism, a 2-hour training on racial issues is not going to get us where we need to be. I was recently listening to a podcast and it said for pretty much any organization, it takes 2 years with 90 to 120 hours of training for all staff to eventually get to the depth that we really need to, especially in a healthcare profession, so that we are having people come to those appointments, recognize their bias, be able to set aside and work through it, and then give that patient or that client the best experience that they can, where they get to show up exactly who they are. Hope that was helpful.
Michelle, what are your thoughts? I'll ask the same question to you.
Sure. So I am in agreement with everything that Chris mentioned. Our organization really works on those kind of structural pieces. So I think, as Chris mentioned, making sure that the forms in a provider's office are inclusive and allow patients to self-identify rather than making assumptions. And then also making sure that we're actually using the information in a way that is helpful on an electronic medical record. I think that a lot of times folks might miss out on screenings that are actually necessary for them based on assumptions about what their gender identity is. And we all have seen the horrible pink mammogram vans that can be really alienating for folks that are trans or gender nonconforming. So I think it's really being thoughtful about those things. And I'd actually just like to mention a program that is run in Vermont that has made some really great strides into making sure that their cervical cancer and breast screening program for low-income folks is really welcoming to gender nonconforming and trans folks. The program was initially called Ladies First, and so they went through a whole process of renaming the program to You First, and making sure that all of the patient-facing materials, so the public-facing materials, were really inclusive and didn't say, Vermont women, but they say Vermonters, and that the guidelines for that program are really clear about being inclusive of everyone.
Thank you.
I
So,
love that. Can I interject and just say, I think that's awesome because, you know, intake forms is one thing, but changing attitudes about, you know, how we treat our patients is something that I think Chris said, you know, really requires a lot of education. 65% of gynecologists are uncomfortable screening transgender patients. 65%, you know, like that's huge. And so even when your waiting area, you know, feels comfortable, your staff, you know, I work in a primarily, predominantly Mennonite community. And so we have a lot of challenges to go through to make sure that we respect and understand and support every single person who walks through our door, no matter who they look like and what they represent and what their identity is. And so there is a huge steep learning curve there for the offices, but also for the providers, because we have some work to do historically and some trust to gain there.
And I actually like to respond to that too. I think I do want to make a distinction. I'm not sure everybody who's participating on this call, everyone may be aware of this, but I do want to make that distinction between sexual orientation and gender identity. I know that we've primarily been talking about gender identity as a part of this particular question, but there's the LGB, which is their common experience is that sexual orientation is the definer of whether you're in one of those groups. T is all about gender identity, which is a separate issue. So I can be gay and trans, I can be gay and cisgender, I can be lesbian and trans, I can be lesbian and cisgender. So you would identify as something in both of those categories. So I just wanted to be clear about that. The other thing I think that as we're learning more and we're getting away from this binary world, even in the trans community, we often see it as a binary. So you have a person who has not transitioned or a person who has transitioned. And that can mean a lot of different things. And I think that one of the part of getting healthcare professionals comfortable with working with this community is the fact that a person can be trans and have done nothing as a part of their transition and can stay there and still identify as trans, or they can have gone through a full transition where they may have taken hormone therapies, they may have had gender reassignment surgery or gender confirmation surgery. These are things that people can do, but a person can identify as trans and they can walk into that room as part of that first appointment and could be displaying they could be presenting in a gender that may not be how they feel. And I'll just give one example. Mine is actually from banking, but I had a customer come in, identified as a trans woman, was 6'5", and had not grown her hair out long yet, had not even started hormones, nothing. And so there was a really great training moment for me and my team as we were meeting with this client and learning to use like she, her pronouns when there wasn't necessarily anything that I had been socialized to identify as female in front of me. And so the training with healthcare professionals that there's a spectrum even within the trans community, there's a spectrum within the GLB community, and so getting away from, I need to be able to identify as much as I can from the person walking in, and really it's going to have to come through the conversation.
Thank you, Chris. One question from the chat that is relevant to what we've been discussing is someone said, I would like to know more about how Dr. Gary's organization is changing their intake form to make it more welcoming to the LGBTQIA community. Dr. Gary, can you elaborate on that?
I can. I think there are some great resources available. In particular, Fenway Institute has a really wonderful resource for medical practices on how to begin to structure your intake forms, your evaluations, your interviews with patients, such that you are getting information that is gender nonconforming and is also comfortable for the patient to self-disclose, such as things like what is your preferred pronoun? Do you think of yourself as, and then having a checkbox or having a blank where people can write in what their response is with respect to their gender identity, asking questions about their sexual encounters and the types of partners that they have sex with, rather than do you have a husband or a spouse or a, whatever. I think that it is really a thoughtful process, and it is not it's not cookie cutter. And so I think every practice really needs to look at what their intake forms say, and what information you need to glean from it, rather than saying, do you perform self-breast exams? Perhaps you say, you know, do you perform chest exams, examinations of, you know, of your mammary glands, of your nipples, of your, you know, and making sure that some of the wording that we use, especially in the breast clinic, really centers around the chest itself. You know, I have a hashtag on social media, hashtag check your chest, because I do see a number of patients who I see male patients, I see you know, patients of all gender identities, as well as sexual orientation, and so making sure that they all feel comfortable performing that exam, you know, is something that's super important. So to that person's question, there are some online resources. Fenway is probably a great one. Human Rights Campaign has another very long PDF that goes over some different types of questions that you can put in your intake process. Changing your EMR, however, your electronic medical record, is a bit more challenging, and you've got to work with your IT department regarding that.
Thank you, Dr. Gary. Being LGBTQ can complicate a cancer diagnosis. And we were speaking about self-identifying, particularly on the forums, and Chris in general spoke that you can occupy more than one identity. How can one's other identities affect the intersection of cancer and the LGBTQ community, including race, gender, and religion? And in what ways can we better recognize the intersectional identities of those in treatment? I'll start with Dr. Gary.
Sorry, I keep putting myself on mute there. I think intersectionality is the buzzword of the century. You know, it was coined by Kimberly Crenshaw, and it really speaks to the lived experience that people have in all of their experience. So being a person of color, a Black person who is also a member of the LGBTQ community, who is also, you know, let's say diagnosed with triple negative breast cancer, who also has mental health issues, who also, so all of these alsos all create a perfect storm of potential barriers to receiving care, to access to treatment, and then to those potential outcomes. So to your question about recognizing, you know, how those things interact, it's first acknowledging that those things do interact and overlap, and that there's some really systemic ways in which it can hinder successful outcomes. And so recognizing those overlapping systems means perhaps focusing on what it means to be a black woman with breast cancer and the outcomes there, and addressing some of the social concerns and some of the cultural concerns there. It means addressing mental health. I think we have not yet talked as much as we should about mental health and depression in this particular community, because that certainly determines your outcome. It determines your willingness to seek out treatment, and to a large degree your success. Things like smoking and alcohol and all of the other factors. So all the risk factors, and it all, I think it's just important to look at all of those things in the context of the cancer care and how that patient's going to do. Because even if we were to provide the same resources, let's say for a cancer patient, where we have acupuncture, we have Reiki, or we have organic produce that can go to your home, if you have no home, if your home is transitory, if you are in an area where you don't have transportation, then your resources and your access are limited. And so being creative and thoughtful about those things will enable us to provide better care.
Thank you, Dr. Gary. Chris, I'll ask the same question to you.
So I'll say the same, many of the same things that Dr. Gary said, I think, but I'll use some examples. So if I was in the majority group in 4 main categories that we've talked about today, so if I am white, and if I am male, and if I am cisgender, so I identify with the gender that I was born with, and if I was straight, I would be in the majority group in all of those areas. Anytime that I step out of the majority group in any area, I tend to lose access, I tend to lose information, and I tend to lose understanding. And one of the main reasons for that is, for most professional organizations, the higher you go up the chain, the more white, the more male, the more straight, and the more cisgender it becomes. And so there is a lack of lived experience and understanding, and it ends up playing out throughout the entire organization. So for me, I'm in the majority group in 3 of the 4 categories. I am an out gay man. Just that, and I'll give an example for me. 10 years ago, I was attacked outside of a bar in the middle of the night. And I was gay bashed by 4 men. As an example, because I was a gay man, which was a unique experience to me, I did not seek medical care after that event because I felt shame. There was an emotional tax to being gay. I didn't want to have to explain it. I did not want to have to talk about what had happened to me. If I'd been a straight man and had been attacked, it would have been much more likely that I would have sought care because I would not have had the shame wrapped up in that experience, not wanting to explain what happened, that sort of thing. That type of thing happens on a lot of different levels to a lot of different marginalized groups for a variety of reasons. And so if I was a Native American woman, cisgender, and lesbian, the experience that I have, and if something traumatic happened to me, or if I was having problems with my body, me going in and talking to someone and looking around and not seeing anyone who looks like me and does not have any of my shared experience, even if I'm not aware of it, it still is a barrier and may keep me from seeking care early enough to identify when there's a problem, those sort of things. So I think that's one piece. I think one thing that probably one of the biggest things that organizations could do to change some of this is getting people who are part of marginalized people groups higher into organizations. If we had folks who were non-white, female, transgender, LGB in the top 4 levels of most organizations, that shared experience ends up playing out in policies and strategies and how organizations work. So I think that's really important. So hiring and retention of those people, those sort of things. Second, I think the understanding is, even if I'm looking at insurance access, if I am white, straight, male, and cisgender, I have the highest rate of insurance access. Anytime that I drop one of those into a marginalized category, my access to insurance programming, all of those sort of things goes down dramatically. And the more categories that I drop in, the more I'm being affected from all of those things. All of that has an impact, and we see it in the mortality rates. I mean, I know one of the best examples most recently that I read was infant mortality, specifically in Black African-American women, and how it's much lower. And it's partly because they go in, they don't have the access, they have been in some ways barred unconsciously and consciously from healthcare. And all of that together can affect it. LGBTQ is one of those few that is considered, can be an invisible dimension. And so people go through that, the emotional tax of, do I disclose or not disclose? And same thing for trans folks.
That's very relevant to a question that was brought up in the chat, especially the idea of, do I disclose or do I not disclose? One viewer asked, what do you believe is an effective or appropriate way for healthcare providers or employees to regain the trust of members of the LGBTQIA+ community, if you believe that to be possible? Sar, do you have any thoughts on that?
Yes. So I do. What we should aim for is that question becomes obsolete, because we should aim for a situation where we don't need to, as healthcare workers, don't need to regain trust, because it's so obvious that that we are not discriminating and are equally inclusive and welcoming to all. So I think when it comes to that, largely one of the reasons that at least my personal involvement to date has been focus to date has been on mentorship and training is that similar to a point that Chris made before, I think that if we get more minority background physicians or healthcare workers into clinic rooms, into hospitals, then that makes it obvious that you are one of us, and so that, I think, is probably the single best, in my view, the single best and most long-standing intervention that we can perform in order to assure that and to make that question hopefully obsolete in the future.
Absolutely. Dr. Gary, what do you think would be an effective or appropriate way for healthcare providers or employees to gain trust of the queer community? And do you believe that that's a goal that we can get to?
I think it is certainly a goal worth striving for. And again, looking at that intersectionality, the medical community has such a long-standing history of mistrust and abuse in the Black community and the people of color, and the LGBTQ community as well. And I think that the first step really is internally making the improvements and seeking the education. And before you can visibly begin to show your transition in terms of being affirming and being a safe space and a welcoming and affirming space for our community, I think there is a lot of work that needs to be done internally. And too often we're too quick to look for quick fixes and check boxes and things we can put on our websites. And so actually doing the work and then being very visible about what that work looks like and why it's important, and being transparent about that transformation is something that I think health systems should do. We need more of that really candid conversation from the leadership all the way down, because I think it's a powerful thing when I see the CEO of my hospital give a talk that speaks to what she experienced looking at patients who have COVID, for example. We developed, as a result of the coronavirus pandemic in our institution, a new diversity panel where there had not been one before, because we saw so many patients who died without a loved one near, who didn't speak the language, who had some significant barriers relevant to our community. And so now there is an outward campaign for that. And so I think along those lines, really being strategic and inviting the members of the community to the table. So not having consultants come in who don't have that lived experience, but inviting those of us who have that lived experience to come sit at this table and to begin to do the work is something that I think healthcare systems can do to begin to restore trust, because you pick those valued members of that community. And I think that shows the worth and the value.
Thank you, Dr. Gary. Last prepared question, we'll be focusing now just on questions in the chat. So if you have more questions, please ask them. But how can allies best support LGBTQ individuals experiencing cancer? Michelle, what do you think?
Sure. So I think that the best thing allies can do is really to become educated about the unique challenges that queer folks going through cancer treatment are facing. I think it's about, listening in on a panel like the one that we're having today. Also, I think it's about noticing, like, if you don't identify as queer or trans, but when you go to your provider's office, are you seeing those sexual orientation and gender identity questions on the forms? And if you're not, ask your provider why they're not there. And I think another really important thing, and unfortunately there aren't many of us who are in the position to do this, but we all should be advocating for more education on queer health for folks who are going into the medical profession, because it is seriously lacking. I don't know the exact number of hours that it is, but it is hours, and it's clearly not enough.
Thank you. Chris, so a similar question, but one that was asked in the chat. How does diversity and inclusion help you move this conversation forward? I know those are very key points for allies, so I think that's a very relevant question to filter into.
I'd like to answer a little bit of that ally question too. I think that as an ally, I mean, I am an out gay man, but in many ways I'm still a part of the majority group. So there's a lot of times that I wear an ally hat more than some of the other hats. So I think that one of the main things that allies need to understand is that part of being an ally means that you are not the center of the conversation. The conversation continues to need to be redirected back to the person who's a part of that marginalized people group. I heard a great explanation of this actually. If you're an ally and you are part of Destiny's Child, you are not Beyonce, you're not Kelly Rowlands, you are Michelle. And so you play a supporting role. See Dr. Gary losing it, yes. But you are a supporting role. Your point is to continuously press the conversation forward to the person who is in the lead. And anytime that your voice is overriding that person, even no matter how much the energy and the passion is there, when you are decentering from the person who's actually at the middle of that marginalized community, you are still doing harm. And so probably the biggest part of being an ally is to not speak. You get to listen. So if somebody is a part of a marginalized people group and they are dealing with cancer, even more so than probably in other situations, your job is to listen and to support and continually keep redirecting back to that person's conversation, highlighting the things that they're saying. You will get your opportunity as a part of a majority group to speak a lot of the time. And so it's going to take some active work to make sure that as an ally, you stay the supporting person.
Thank you, Chris. One other question from the chat. I recognize that this is a little bit more focused on endocrinology, but perhaps Dr. Gill or Dr. Gary can give some thoughts, particularly Dr. Gary, because you work in the chest arena and that's something that can be affected by hormone replacement therapy. One question was, how does undergoing gender-affirming hormone therapy affect a person's cancer treatment options?
So affecting their treatment options, certainly I know it affects their cancer risk, and there is an elevated risk of particularly breast cancer associated with estrogen therapy, but many of the treatments for breast cancer especially are anti-estrogenic. So, things like tamoxifen and some of the aromatase inhibitors, and I think Dr. Saar could certainly, Dr. Gill could speak to this as well, in that, blocking estrogen is a key component of the systemic therapy for things like breast cancer. And so those hormones would likely need to be stopped, or you need to really spend some time negotiating between your medical oncologist and your endocrinologist. But I think if the source of your cancer, if it's estrogen receptor positive, it does create some challenges there.
Thank you. Dr. Gill, do you have any thoughts? I know this is a little bit more in the endocrinology area, but.
I completely agree that in those situations where there are, where one is taking hormones and those interfere with, well, actually both in the direction that Dr. Gary mentioned, as well as potentially in the situation where one takes testosterone, for example, not necessarily for prostate cancer for several reasons, but rather there's various other complications such as blood clots, etc., that can worsen in those settings when one is taking hormones. So I think those are largely, you're right, Finn, they're endocrinological questions, and those are, to my mind at least right now, the major situations where gender reassignment may interfere with, or at least interact with, the treatment.
Thank you. One question that I think Chris might be able, once again, this is a little bit more focused on like developmental and things like that, but maybe Chris could give a little bit more of insight around this terminology. A question was, at what point in development is a child able to decide what gender they are or want to be?
So this is one of those great questions where the answer is, I can't give an answer. So there is information, studies that have shown that children that identify with a gender, that are either gender non-binary or identify with a gender that they were not born with, early identification can be helpful in a lot of circumstances. As an example, I know that there was a study done on folks who did early transitions, say 11, 12, 13 years old. So actually transitioning to being transgender pre-puberty. And the risk, for instance, to suicide, depression, anxiety was 6 times less likely in children that were able to transition before puberty. So that's one example. There are children that have transitioned, with parental supervision as early as 4 or 5. But there's still studies being done. And so I actually cannot give an answer to this question that may be as definitive as people want. What I would say is, if there is a child who looks like that they possibly could be trans or gender non-binary, it's in conversations with guardians and medical professionals, including mental health professionals, that will help make that decision.
Chris, just to follow up to that, what is your kind of, from a DEIB perspective, what is your thought about using the word to decide around gender identity?
It's a great question. I saw something earlier today, even, like, when did children decide to be straight? There was the assumption, right? When did children decide to be cisgender? a child is transgender or they're not. And so there is not necessarily a moment of decision. What they have seen is there is, as just like with any growth that any child goes through, is that there are moments of realization and expansion of their view of either their own sexual orientation or their own gender identity that happens exactly the same as children that are cisgender or are straight. And so it's really just that expansion and growth that they will be able to uncover if they are trans or cisgender. Does that answer your question?
Yes, thank you for that clarification. Another question in the chat is, because of the unique medical obstacles of all members of the community face, how can medical providers balance seeking these personal insights about patients' LGBTQ identities, which can be crucial to personally tailored care, while also respecting boundaries and not pressuring patients to come out when not ready? That seems like a tough line. Dr. Gill, what are your thoughts?
Thanks. That's a really good question. And I think it is part of the respect that one pays to any human being. So when I have a patient in front of me that is, we spent the last hour or so talking about the importance of all these issues in access to delivery and even aftercare and survivorship, which we haven't really touched on yet. But I think it is part of a good, solid, trusting, compassionate relationship between healthcare provider and patient for us to respect each other's boundaries. And so I think that it is part of the rapport that you build with a patient that is part of being a good physician.
Dr. Gary, I'm going to ask the same question to you. What are your thoughts?
I would agree with Dr. Gill. And I think also, asking the same questions the same way and normalizing your interview and your conversation really opens the door for a level of normalcy, and it legitimizes a patient's experience such that, if you're asking questions about sex, you can say, are you sexually active? Or you can say things like, I ask all of my patients the same questions the same way. Are you sexually active? When you have sex, what type of sex do you have? Or how many sexual partners have you had? Do you have any issues that you would like to discuss regarding intimacy, regarding your sexual identity? And asking about those things in a way that says, if this topic is not comfortable for you, I certainly respect your right to move on. We don't have to discuss these things, and making sure that that your patient feels comfortable. So I think asking the same questions the same way is a great way to begin to normalize all of the conversations about gender identity, as well as sexual orientation.
One final question of this portion before we break into the breakout rooms part of this conversation, and I'll ask it to everyone. What perspective do you feel like is missing, and how can we even broaden from here and be even more inclusive from here? Chris, what are your thoughts?
I believe that we are still in like the infancy stage around how training can be integrated around this work. I think that a lot of times we see it as a separate, when people have diversity inclusion discussions where they have consultants come in from the outside, it seems very separate. It just happens on a day. It just happens in the afternoon. And it doesn't seem to be well connected to the work that happened before that meeting and happened after that meeting. So I think that there are ways that institutions and organizations can weave this in a much more organic and constant way that I think that could be helpful.
Michelle, what are your thoughts? What do you think we can add to this perspective, and what do you think is missing in this conversation?
I think that we need to be thinking in a macro level about the data we collect on our patients. I think that if we don't know that a problem exists, then we don't do anything to address it. So again, I'm really going to bring up this asking about gender identity and sexual orientation at doctors' offices, but then also, in large national health surveys. For many states aren't collecting that data, and it's something that we really, really need to focus on.
Dr. Gill, what do you think we need to add to this conversation and to look at from another perspective?
I think that the theme for me is what I think I started off with, which is that what we should be focused on the end goal of this. What are we shooting for? Where do we want to be? And since we're focused and wish to achieve equality, then that's our goal. And to me, the visualizing that and getting to a stage where it is a complete, ideally non-issue. I mean, that it isn't a matter of being in the majority or not, because we're all, in a sense, in the majority as human beings. So getting to that point, keeping that goal in mind, and I think being goal-directed, that helping to ensure the success of achieving that, or to accomplish that goal, relates to visualizing it. And so, how would I want to be treated in a particular setting, and treating people in that fashion? For us on this call, on this panel, it's kind of obvious perhaps because we are part of that. But if we can, through education, training, experience, people who confer on people who don't belong to at least one minority group, that concept as archaic, and I mean that in a historical sense rather than in an obsolete sense, as archaic as it may be, that you should treat others as you yourself would want to be treated. I think that's the goal we should have, and ideally, whereas right here in this conversation we're talking to each other and to people who are either caregivers or who live with cancer or who have done so previously, extending that to the community and beyond LGBTQ community, and extending that to other healthcare workers is where we should be going.
Thank you, Dr. Gill. Before I get to Dr. Gary, Chris put something in the chat, and I think it would be good if he added it. So, Chris, what were you putting in the chat, and how do you elaborate on that?
Yeah, I just wanted to say, there have also been studies done that, through training will get us to a certain point, but often training is only effective with those who are already willing to engage with material. And so, if I worked for an organization and we had a half-day training on, handling gender well in the workplace, so talking about misogyny or gender identity, those sort of things. Education will have the impact on the people who are willing to listen and are willing to engage, but there will be people who may not feel that. And so there needs to be a step further beyond that, where we're actually linking it to policy. So it's not just, you've now been a part of this program, we expect you to act this way. Now that you've been through this training, here's some actionable steps that we'll be checking on to make sure that you're actually internalizing this behavior and it's being displayed to all of your patients. And so it would show in policy. And then further than that, I believe that diversity and inclusion metrics should be tied to performance. So if you are in an organization and you've been to a lot of trainings, but you continue to hire only white, straight men, I think there should be an impact to your compensation or to your performance, that you are not necessarily living out all of the values of the organization. And so that's what I meant by that.
Thank you, Chris. Dr. Gary, some final words on this portion of the discussion before we break into the breakout rooms. What do you think should be added to this conversation, and what perspective do you think needs to be seen? Oh, you're muted.
Sure thing. I totally agree with everything that everyone has said. And I think things that are missing from this conversation, well, certainly the voice of the patient with the lived experience with cancer, I think is an important and powerful voice, and stories that need to be heard, because, we can pontificate and we can describe our experience as providers, et cetera. But, when you talk to a patient who has gone through this experience, it changes you. And it transforms your perspective about this topic. I think that a collaborative initiative with other organizations is something that we should be moving towards, and something that we can discuss. What do our action items look like from here with respect to collecting some real world data and empowering patients. So there are a number of new and emerging platforms that allow patients to input their own data to see what clinical trials they might be relevant and applicable for, that enables us to look at the demographics in a way that our standard intake forms and electronic medical records do not. And so I would foresee that as a result of these types of discussions, organizations like ours would begin to take the lead in those areas and develop things like registry trials whereby patients can go to these sites and input their own information so that we can begin to really see what the issues are, what the demographics are, what the challenges are, and give that power to the patient themselves. So I think missing from this conversation would be, actionable things to do next, and then education for clinicians, for medical trainees, for students, and that accountability factor that Chris mentioned, calling some of those healthcare administrators to the table to join in this conversation and really creating a pledge of sorts that holds them accountable for some real change.
Thank you, Dr. Gary. Thank you all for your insight, Dr. Gary, Dr. Gill, Chris, and Michelle. Thank you for your participation as panelists. That wraps up the first portion of the event, and the recording will be ending